Welcome to the CHCI Fall Health Summit Closing Plenary. Healthcare from the Future, Advancements in Health Technology Today. This plenary is possible due to the gracious contributions from our sponsors, Illumina and the Commonwealth Fund. Our plenary host is Congressman Raul Ruiz, MD, representing California's 36th Congressional District. Dr. Ruiz currently serves as chair of the Congressional Hispanic Caucus and serves on the House Energy and Commerce Committee and the House Veterans Affairs Committee. Welcome remarks will be provided by Dr. David Blumenthal, president of the Commonwealth Fund. Our moderator for today is Bertha Coombs. She is a correspondent for CNBC, covering financial markets, business news stories, and healthcare. She has covered the implementation of the Affordable Care Act and the failed launch of the Obamacare health insurance exchanges, to how cancer researchers are using IBM's Watson to improve cancer care, mobile technology, and telemedicine. Please welcome our opening remarks speaker, Congressman Raul Ruiz, MD, followed by Dr. David Blumenthal.
Good afternoon. My name is Congressman Dr. Raul Ruiz. I represent California's 36th Congressional District in Southern California. I'm an emergency medicine physician and a public health expert with training in humanitarian and disaster aid. I'm also chair of the Congressional Hispanic Caucus. It is a pleasure to be with you at the Congressional Hispanic Caucus Institute's 2021 Fall Health Summit as we look to discuss advancements in health technology today. Before I get started, I'd like to say a special thank you to CHCI for all the incredible work you do to develop the next generation of Latino leaders. By providing leadership, public service, and policy experiences to outstanding students and young professionals, you're helping set students such as Tarcisio Trujillo, who is a CHCI intern working in my office this fall, on the path to success. And as a son of farm workers and the first generation of my family to graduate high school, I understand firsthand the importance of creating opportunities for emerging Latina leaders that will create a brighter future for us all. In the last year, we have seen Hispanic families disproportionately affected by the COVID-19 pandemic because of a lack of access to quality healthcare and insurance coverage. The CHC is committed to eliminating the barriers in healthcare that Hispanic families face and creating innovative solutions to deliver progress for our communities. This year, we have seen advancements in health technology through telemedicine, robotic surgeries, artificial intelligence, and virtual reality that have benefited thousands of patients. The future of healthcare lies in the hands of those who have the capacity and are quick to adapt to new innovation. It is exciting to live in an era where we can use technology to help others live a healthy life. CAC members are committed to continue to work with biomedical engineering and health tech companies to ensure Hispanics have the same opportunities to attain the best treatments available to the American people. So thank you for having me today, and thank you to CHCI for strengthening and empowering Hispanic communities. Together, we can create lasting change to ensure the promise of America is accessible to the 62 million Hispanics living across our country. Thank you.
It's a great pleasure to be here on behalf of the Commonwealth Fund and to have worked with and continue to work with the Congressional Hispanic Caucus and the Congressional Hispanic Caucus Institute. The topic today is healthcare technology and its implications for the health of Latinx Americans. And let me start by saying that the implications are huge, not completely knowable, full of promise, but not without peril. We now have more information about the health of Latinx Americans than we have ever had before, located in the cloud, in the history of our country and in the history of the human population. If we can tap that knowledge effectively, as it lies buried in vast stores of digital data, and apply it widely and fairly, we can improve the health of Latinx populations in ways never before contemplated. And the digital revolution also creates opportunities to realize benefits through overcoming barriers of distance and expense to getting care, especially in remote areas where so many Latinx people reside. But there's peril. New technologies are almost never made equally available to marginalized populations. Latinx individuals start with less access to care on many dimensions. Despite the enormous advances of the Affordable Care Act, they are less likely to be insured, less likely to have a usual source of care, and more likely to have foregone care because of cost than Black Americans or white Americans. This pattern of marginalization makes it less likely that Latinx will fully enjoy the benefits of new digital technologies, not just of telehealth, but also of sophisticated algorithms that can support not just clinicians, but also patients in choosing care for their loved ones and themselves. It may also be less likely that those huge reservoirs of data will be used for the full benefit of Latinx populations. Though I was encouraged to see that just yesterday, the Food and Drug Administration issued guidance on the development of artificial intelligence that said it should be based on populations that are representative of all Americans. So it'll be important that elected representatives of Latinx populations keep their antennae primed for opportunities to use new technologies to the advantage of their constituents and not let past be prologue with respect to these new vital and powerful tools. Thanks very much.
I am a reporter with CNBC, and I am very pleased to have been invited to lead the discussion for this closing plenary. Title of our discussion today, Healthcare from the Future, Advancements in Health Technology. And today, during this day-long virtual health summit, this is probably one of the key issues that so many of us think about in terms of healthcare. First, I would like to thank Marco Davis, Congressman Raul Ruiz, and Dr. Blumenthal for setting the tone for this discussion. And thank you to CHCI for providing a platform to discuss this important topic of health technology in the Latino community. You know, this pandemic, as Dr. Blumenthal alluded to, the pandemic has really helped put healthcare technology at the center of care. What people had forecast for years, virtual doctor visits, monitoring patients in their own homes, leveraging electronic health records to mine data to help us figure out how to fight disease, in this case, COVID in the hospital. It all was accelerated in a matter of months. But as we look to integrating more technology into everyday care, the question is whether it will help address health equity in the Latino community or create more of a social divide and more barriers to care. As always, we want to hear from you. We want you to be part of this conversation during the discussion. Please use the chat feature at the right of your screen to comment or ask questions. And of course, you can continue the conversation on social media. Be sure to use the hashtag CHCI Summit. So we've got a great group of leaders on today's panel, and I'm going to ask each of them to introduce themselves and tell you a bit about their organizations. And I want to start with each of you to talk about why you think this is so important right now, the issue of technology and healthcare in the community, the Latino community. Mario Anglada, let's start with you.
Thank you for the invitation this afternoon. I lead and founded Oi Health, a telemedicine remote patient monitoring medication access platform that was built with the impetus of creating solutions to those in underserved communities. We started out our journey as a Latino-focused company of providing direct access of our solutions to patients. We've expanded over the last couple of months and during the pandemic to offer our services to healthcare insurance companies, hospitals, clinics, and other stakeholders in the healthcare continuum. So we are really excited to participate here today because we think that we are at an inflection point where the technology adoption that has occurred in many instances forced by the pandemic actually have shown the healthcare stakeholders a way where the patient actually can benefit from these interactions. And we're leading the charge in the vulnerable populations in the locations where we participate with our partner organizations. So we're happy to be here today and thank you for the time.
Terrific, Mario. Next, our next panelist is Bruce Taylor.
Bertha, thank you very much. My name is Bruce Taylor. I represent the diabetes community. I'm the Senior Director of Advocacy, Policy, and Government Affairs for a company called Dexcom for continuous glucose monitoring. I'm also the board chair of the Diabetes Patient Advocacy Coalition, and also a patient diagnosed over 43 years ago. So I understand personally the impact of a chronic condition like diabetes, especially with the six-fold prevalence within the Hispanic population, and how access to this technology, when Mario talked about remote monitoring, we now have technology in a self-managed condition like diabetes where patients can see their numbers and make the choices for their medications, diet, etc.
Terrific. Thank you so much, Bruce. Our next panelist is Dr. Phil Fabro.
Thank you, Bertha, and really appreciate this opportunity to speak. I'm Phil Fabro, Chief Medical Officer at Illumina. And at Illumina, we make DNA sequencers and microarray technology, and increasingly see that an individual's genome will become part of their health and their healthcare. And I think the conversation we're having today is so important, Bertha, because the pandemic has shown the incredible opportunities we have with technology today in the setting of an extreme stress like a pandemic. And Mario and Bruce already talked about how we've seen an incredible uptake of remote monitoring. From sequencing technology is available enough that sequencers identified the virus within a month, tracked the virus as it spread across the globe with different mutations, and tracked the emergence of variants. Sequencing was also the foundation to develop the vaccines. And in the first time of mankind's history, vaccines were developed and clinical studies performed for authorization within a year. Before that, it took 4 years to get to the same level of evidence. At the same time, the pandemic has also demonstrated there are real challenges that continue in vulnerable populations. And there's incredible risk that vulnerable populations do not get ready access to these advances. So it's a very timely conversation. I'm happy to participate and provide our perspective.
Great to have you. And last but not least, Dr. Adrian Boise.
Thanks, Bertha. So, hi, I'm Adrian Boise. I'm the Chief Medical Officer of Qualtrics, an experience management company that helps organizations and people both care more effectively and optimize care for patients, customers, and their own people. I'm also a practicing neurologist at the Cleveland Clinic and a master's trained bioethicist, as someone always fascinated with why we do what we do to people in healthcare. I think the conversation, I agree with my colleagues on the panel, certainly very timely. I come at it through the angle of wanting to make sure that as we talk about vulnerability and inclusiveness of different populations who we're trying to design interventions for, that they are part of that design process, that we're listening intently to their voices and acting upon what we're hearing. I think that's paramount to any fabulous design that's equitable, accessible, and creates value for the people we want it to. Thank you.
Great point. So I want to start off our conversation with the question of, where do you think we are in the cycle of health technology right now? It seems that for a decade we've been talking about things like telehealth, things like remote patient monitoring, things like being able to leverage data to improve care. And over the last 20 months, we saw probably years of progress. Are we continuing on that pace, or are things falling back a little bit? Mario, I see you nodding. Let's start with you. What do you think?
My personal opinion and what we've seen in the market so far play out is that for the vast majority of consumers, there's a little bit of retrenching, right? Because now that you can actually visit your physician, a lot of the traditional patients that have access to healthcare, have good healthcare or good coverage, are able to go back to an in-person relationship. Where we focus on and what we've seen is that populations that were historically vulnerable have now found a pathway for them to have care in a supportive environment that can take away a lot of these challenges that these populations have. So in our case, it's access, cost, and availability of resources. So when you look at certain subsets of the population, the ones that we focus on are the most vulnerable, we think it's probably here to stay, and our clients are expanding our service offering with them because they found an effective way of achieving that with these subpopulations that we focus on.
The beauty of your app is that it's in several languages, and key one, of course, being Spanish for the Latino community. It has a very sort of simple interface. Bruce, I want to talk to you about how important it is to make it sort of seamless, and particularly when you're talking about vulnerable populations, so that it's not this technology that's so foreign coming into them. I mean, how hard is it to convince someone to wear a glucose monitor?
It's, at the end of the day, once the clinician talks with the patient, talks to them about the value of it, in years past, you would have to use a lancet and a strip with a meter and literally perform a lab test if you were on insulin before and after every injection of insulin. Well, as a patient doing that 10, 12 times a day for 30 plus years, somebody offered me, hey, you can wear this sensor and not have to stick your fingers. Sign me up. And if you look at the app, it puts everything into perspective because it shows a graph and not a number. And people understand universally a graph. If it's going up, my sugar's going up. If it's going down, my sugar's going down. And with very little training, part of the adult learning process, our parents told us, don't put your hand on the stove. Well, how did we learn? When they were bandaging our hand. And patients have that adult learning experience, and it meets patients where they're at with their lifestyle. And to Mario's point, we have to go to where the patients are and meet where they're at. And I think that's what technology is helping to serve.
Dr. Fabro, research is such an important part of all of this. And one of the things that we've seen is we've got greater technology, we're trying to make it easier to sign people up, and yet we still don't see that representation. It's one of the things that the AMA has talked a lot about, that, if we're going to develop this technology, we can't just make it for enterprise and just for, Silicon Valley, not to pick on them, but it also needs to meet people where they are and bring more people in. Are you seeing that shift?
Well, Bertha, we are seeing a positive shift, as you said. There's been a trend in healthcare to move from hospital-based to clinic-based, and the pandemic really has accelerated a move to home-based. And what Bruce talks about, monitoring and apps like Mario's group have developed, are super important. And we're also seeing research move that way too, with the FDA supporting decentralized trials where people don't have to incur the expense of the transportation, the expense of childcare to go to a center to meaningfully participate in research studies. So that is being helpful. At the same time, we have to be cognizant that even though it's moving to the home, not all homes have access to broadband. I saw a study from Somos where 60% of Latino homes in this study had access to a computer and broadband. That means 40% did not. And so we have to be fully cognizant. And my hope is that as we come out of this pandemic, we realize that it's not one size fits all. That in order to fully engage a vulnerable population, there has to be a mixture of opportunities for those to meaningfully participate. And we do have a significant, what I would call a diversity debt, specifically in genomic research, where we have a lot of information about a Northern European ancestry. But we have very limited information and to draw upon to really have some of these fundamental advances for health and healthcare for many populations in the United States and abroad, where we just don't have enough information yet to have those populations fully benefit. So we have to address these challenges. I think the pandemic has shown us a path, but we have to stay vigilant because there are still significant challenges that have to be addressed.
Is technology a way to help sign up more people or at least reach more people? I know that Apple, through its Health Kit, had tried to do an initiative to help companies do that, and 23andMe, you pay them $200 and they're going to take your DNA and try to help develop drugs and make money from that. But at the same time, trying to bring more people in.
Yeah. Well, I think it can be a solution, but there's many different people have different perspectives on and have different levels of trust with healthcare, with research. And that's because, I think there's been differences in trustworthiness on the part of healthcare and different, certainly, research projects, certainly in industry. So we have to find the right balance where not only do we work to establish more trust, but we ensure that the entities that are looking to engage broader communities, vulnerable communities, so that there can be research, so that the benefit can come back to those communities, that those communities feel like the entities are acting in a trustworthy fashion. So it makes sense for them to participate, because a lot of times, even with technology, we still need people to choose to participate, and a lot of that's based on trust.
Dr. Boise, you deal with patients, many of them disabled with multiple sclerosis. Is it even harder for patients who are people of color, Latinos, who might be in vulnerable communities when they have to contend with those kind of disabilities?
Well, I think it's lots of different layers to that question. I mean, it's not simply unidimensional, right? It's not that you're disabled and therefore you have more problems or you're from a vulnerable population. It's all the things that some of my colleagues on the panel suggested. And I would add, in addition to having chronic disease, less likely to have insurance, less likely potentially to seek care, more likely to use their phone for care as opposed to going into an office. You also see different levels of engagement and lower health literacy. Mario brought that up before, and I hope he will speak more to it today. There's so much stigma around mental health, which invariably accompanies chronic diseases. There's so much stigma around what you're able to do or unable to do physically. And I think we have to recognize that for already vulnerable populations, the burden to work harder, to listen more intently, to go where they are as opposed to where we are, is much, much higher on healthcare clinicians like myself, as well as healthcare systems. And I think the things that we also mentioned, the lack of transparent costs that's rampant in healthcare, the lack of transportation that we readily make available. When we set up a single barrier for someone who's already stigmatized with a chronic disease, who may also have mental health, they're gonna, if it doesn't work the first time, that user experience is over. And I think we've lost a patient who may not have really trusted us in the first place. So the responsibility is great to make it easy, to make sure we know who our patient is, the methods they prefer to engage, and how their behavior over time really impacts that. Because a lot of people will say, oh, I want educational videos on my diabetes or how to test myself. But the truth of the matter is they don't watch them. So we don't need to just understand what they say. We need to understand the unmet, unsaid behavior patterns that can teach us more about who people are and how we can better engage them.
Is there anything from the pandemic that has helped any of you, just from your own experience, helped you think about what actually might work, what works better? I think about the fact that we saw such a concerted effort to go into vulnerable communities and have people actually communicate one-on-one, whether it's going to, churches so that there's that trusted person, or finding that trusted social worker who can really help deliver that message, and as much as we talk about technology, a lot of that happened face to face, a lot of that happened door to door. Are there lessons to be learned there that you think we can continue?
Well, I'm happy to
Well, I
jump
certainly
in.
can think of, yeah,
Phil can go.
go ahead. Well, I can think
No,
of
I
a,
was just-
you know,
You guys go here.
really,
Don't let just me ask the questions.
go ahead,
I
Adrian.
like it when it's more of a flow, free flowing conversation. So have
Sure.
at it.
Just some quick reflections. I mean, first of all, I want to celebrate too that the pandemic, for all of its awfulness, one of the benefits, I think, is it also got us talking about the person-centered experience. So not just the experience of patients, but the experience of our own people, right? There's much more interest in how do we message about vaccines? How do we make sure we're connecting to understand people's fears of our own employees and staff as we face a staffing crisis, as much as there are benefits to the patients. And I completely agree with you, Bertha. Knowing your customer or your patient, as I would prefer to call them, is about understanding how best to engage them. And if we're talking about a population, again, with low health literacy, lower engagement, i.e. defined as taking advantage of the resources available to them to manage their health, then we have to be really creative. And oftentimes trust, as defined as keeping your promises to people over time, depends on relationships. And often those are human. And I would say that even though there's a lot of excitement about technology, I still am surprised by patients that still want face-to-face. So I think it isn't a one solution fix all. It's really about knowing who people are so that you can best engage and connect with them. All right,
Bertha,
Phil.
it was interesting.
Go ahead.
One of the interesting pieces, and sort of a key learning, was this trust factor that Mario talked about. One of the things that we learned in the Hispanic community, if we're not talking to the parish, we're not talking to that community. And if you look at faith-based ministry, that's who they trust. If you don't understand the concept of and Mario, please help me, I know I'm going to mispronounce this,
Sure.
prematuros, is that they trust someone from their community. I'm the gringo going down south. And they you have to understand that trust. And if you look at communities of color, even if you went to an African American community, you just say the word Tuskegee and you have a great understanding of why they don't trust the healthcare system. And we have to break down that barrier through their way of communicating to their community. And once you get that blessing, if you will, then you start making progress, but it's slow. It's one patient at a time. And it's, again, to that point, Phil talked about, you got to build that trust over time. It's not just, first date and you're married.
I think Bruce is absolutely right in things that he's mentioning here. What we do at OI Health is we try to take an approach of guiding people through the process, right? Because the first step that you have to do is you have to understand what people are doing. If I'm at the poverty line or below the poverty line, guess what? I probably have 2 or 3 jobs just to survive. If I have 2 or 3 jobs just to survive and you're telling me I have to go to your office at 8 a.m. in the morning, I missed probably the first job, probably the second job. I'm going to go to work sick. So what we try to do is we try to say, let's go through the patient wherever they might be. And that can be in the rural mountains of Puerto Rico, or that can be in the Midlands in Texas. It doesn't really matter. The dynamic is once we get there, we understand the value of education. We know all these really important things that everybody's talking about, which are incredibly important. But our definition starts at engagement. I need you to get to do an action. If I can get you engaged, and it has to be in a reciprocal value transference. The problem that you described a while ago is that everybody's capturing information from a patient and there's no value transference back. So what we said is, listen, we're going to help you guide yourself through the process. If you have a coach with us, we're always here to answer, but you are going to be driving and we're going to teach you in our model 5 things. These 5 things are the only things that you have to do every single day. When you start creating that cycle of engagement, all of a sudden, the layers of the onion start peeling away and you can get into more meaningful, longer term relationships But the points that are being brought are really important to understand. It depends on who you're going to and how you're going to them. And if you want to go from, hey, I'm here, give me your blood pressure measurement, that's never going to work. So you have to take it one step back. We start at a third grade education level, because if you can't understand what we're talking about, guess what? I could create the best videos in the world. You're never going to understand them. So we believe it's a guided process where sequence of events that are very simple, brought to the community by the community, is probably where we can see a great inflection point into the problems that we're talking about here today.
You know, one of the things coming from someone who isn't in the healthcare system that I get very frustrated with is that there's been so much talk about being able to do data, to assist with social determinants of health, and all the wonderful things that we can leverage technology to do. But, you know, I was a caregiver for 5 years, and there are a lot of people who are taking care of abuela or papi, or, you know, or their spouse. And when you are the person trying to coordinate that care, it can be incredibly frustrating that if you're not within all one health system, one silo, it's very hard to be able to get that information to communicate. Even something as simple as when that medication changes, you know, that blood pressure medication changes from, you know, 15 micrograms to 10, or vice versa. It's just, it would be great if there were, you know, we don't have a national health system where you have one health record, but when are we going to get to the point where there really is that interoperability? We've got the privacy part of the portability, but not when it comes to being able to port your information to be able to get better care. Dr. Fabro, I see you nodding.
Well, there are, incredible challenges, right? We always have to find the right balance between privacy and transportability of data. I think it can be incredibly frustrating, and I do understand for caregivers navigating our healthcare system, it's really a challenge. And I think about something I recently heard where someone I was talking to says, well, the healthcare system, that makes no sense because we're not healthy, no one cares, and there surely ain't a system. And, your comments strike that. Now, the opportunity is to leverage technology to start bringing these together. There is increasing interoperability. There is increasingly secure cloud storage. We do have the technologies that have the potential for a functional system. And when you bring systems into the communities in a way that makes sense, it's quite clear people will participate. I think about a specific example during COVID, where in the San Francisco area, we were not seeing many tests from the Latino community for the public health system. They just weren't going into the centers. Well, Joe DeRisi at UCSF and the Chan Zucker BioHub set up a testing center at one of the Bay Area Rapid Transport Centers, and there was incredible utilization and incredible receptivity to the testing, and incredible receptivity to testing was positive, having those people that they've talked to come into their homes about, if they were positive, who were they interacting? They had incredible engagement. So, there is technology can be leveraged, but you have to find a way to bring that to communities that will make sense for those communities, and through avenues and people that those communities trust so that they can take advantage of that.
Is there a willingness? I mean, Adrian, I know obviously the Cleveland Clinic is a premier health system, and you have great technology, and you are out there in the community. But, if suddenly I were a Cleveland Clinic patient and I happened to fall in Boston and have to go to Mass General, is there going to be good communication for me?
Well, I can't speak on behalf of the Cleveland Clinic per se. There are tools, although there are about 50 tabs currently in the electronic health record on the top and on the side that click open to another 50 tabs each of what clinicians can do in the EHR. There are opportunities to share your record everywhere. So wherever you are for care. Patients long ago told us this was important. They were developing what they called patient passports, so that they had their own record too that was portable with them. And so again, I think some of it goes back to we have to be really intentional about listening. I'm going to keep belaboring it because, for example, part of how we hear about the experience of many minority populations in healthcare is through traditional satisfaction surveys or patient-reported outcomes, of which the response rates are low. And when I say low, I mean somewhere on the range of 22 to maybe 30% if you're lucky. Yeah. And those are usually coming from college-educated, non-Hispanic white people over the age of 65. And so to even
I will tell you that I never filled them out until I would have bad experiences, because I thought, I'm not going to let them put out a net promoter score that says they're great when they've done a really bad job.
Yeah, well, I would submit to you that if you trusted me with your good or bad experience, and I don't respond to you to follow up and resolve it, then I have further lost trust and lost engagement and lost ground with you. And that's the current state in many healthcare systems today. Using that tongue in cheek, given what Phil just said about healthcare systems. But that said, we have a tremendous opportunity to hear more from the people who matter and can shape the design of these tools and systems to work better for them. But I'll tell you, the responsibility to do something with that feedback is tremendous. And Bertha, if you told me about your caregiving experience or your poor experience with your loved one, and again, I don't change or I don't have a reach out after that, patient feedback without engaging around their feedback is a brilliant disengagement strategy. So I think there has to be a commitment to listen and to do with what we hear, and to recognize that our current systems are not enough. We need new ways of listening.
But to answer, Bertha, directly your question, there are solutions. So at Oi Health, we give every patient a record that they control and they share with whomever they want. And we built it from a community-based perspective because we're addressing the populations that are vulnerable by design. They probably don't have health records or have structured data. So by going into the community and creating a data entry point that feeds a record that patient controls, and by connecting that to health information exchanges, to other health records with partner systems that we work with, we're actually achieving that goal. So there are ways of doing it, but you have to relook at the system from the ground up. I understand the great services that a Cleveland can have or a Mayo can have. The reality is the population that we're talking about at this point in time are in communities that probably have never had access to that. So what we took our mission at Oi Health was to create a record that says, let's start in the community, let's get that information, let's transfer value to the patient ultimately, and let's make sure that the stakeholders then are able to connect to get these new data points, because that patient, once we have them engaged, they can share their information freely. It starts creating a virtuous cycle within the healthcare system. So we already have that system up and running, and it's connecting Puerto Rico, and we're currently across all 50 states. So there are ways for this to happen, but there are barriers as well, right? If we went to connect to the traditional big records, somebody would have to pay the tune of $1 million for that to occur, right? It's an imperfect system, but it's actually, there are ways of doing it.
Before we open it up, we're going to open it up for questions in the audience in a couple of minutes here. But that is what I wonder, is that the main impediment here? Because obviously we've seen administrations on both sides of the aisle have been pushing for this for more than a decade in terms of interoperability, in terms of letting patients have access to their own data. And yet we keep seeing so much resistance from the major health systems that some of them would rather just pay a fine than put out, transparent pricing for their hospitals, just because it's too complicated.
I can speak about our experience at Oi Health, and it's not bad, Bertha. When you create a community-based record, and that record is value additive to all the stakeholders, including the hospitals, the clinics, and the patients, you get engagement. The reality is there are stakeholders that are in the value chain that's a challenge too, but it depends on how you build it. So if you go to the community and you build it from there back up, you're getting new data sources, and those data sources by definition are needed. So our experience to date has not been that we are able to do it. I think there are other institutions that are already doing that, but it's going to take a concentrated effort. Our approach was to say, let's do it in the most challenging patients because by definition, they need the most help. But if you build it there and you start there, then the interconnectivity to everything else becomes that much easier. But that's our corporate philosophy and mission.
Bruce, are you finding that particularly with diabetes being such a big issue and in communities of color, that is one area where there is more interoperability?
Well, we're seeing a certain level of interoperability through the system that we have. Patients can share their data with up to 10 different people. My data is shared with my wife and both my daughters. They get the same alerts that I do if my sugar goes too low or too high, and they communicate to me via text. During the pandemic, I never saw my endocrinologist in person, but we had the meetings virtually, but he had full access to all my data. So other than a filament check to check for neuropathy on my feet, it was this exact same visit that was fact-based. So if we made changes on insulin ratios, it was all based on facts. Because if a physician doesn't have data and they ask a patient with diabetes, well, how are you doing? I'm doing good. How are your sugars? Oh, they're all good. And they know that's not right.
Right. Without the
But
data.
this way, it has to do it. One of the other challenges is integrating the downloadability of these devices into the EHR. And part of that impediment is that one of the side effects of COVID is that physicians are now employees of large integrated health networks. And the IT people, they're just trying to keep the trains running and keep the EHR from crashing as physicians see patients. So I have to make sure that that doesn't crash. I have to make sure that my analytic platform is there to be able to do my HEDIS scores and all the quality scores that they have to do. And I have to have an operational component to be able to do the billing for the services provided. So how do you get in the tier with the IT queue of then how do I get this data, whether it's Mario's data from a community level, from the device world? We're seeing it with portable EKGs. We're seeing it on a lot of different technology. How do I get that into the EHR? Because that saves times for the clinician. He or she can look at that record before they walk into the patient room and be better prepared to ask the questions.
Yeah.
So that we're getting therapeutic inertia and it's not the tyranny of the urgent.
Well, speaking of questions, we're getting some good ones in from the hospital. Go ahead, Phil. You can finish up.
I was just going to add, and I think what Mario stated is, that example is so important because I do think when you take a patient-centric approach and more empower the patient, it's much easier for patients to integrate now their data and really take control of that than it's ever been. I think what we've been waiting for is a top-down approach from the medical systems, and that just hasn't worked effectively for some of the very reasons that Bruce just outlined. So this kind of the patient empowerment that programs and companies like Mario's enables, if the Latino community embraces that, and I think there's a lot more opportunity for participation and getting that kind of transportability of records.
So we've got a question from Chris who says, what does the future of healthcare look like for populations that are not yet tech savvy? Adrian?
Well, I think it circulates around much of what we've been talking about, which is in order to move the needle in health for patients that aren't tech savvy, and I would submit everybody's probably a little bit tech savvy. The question is, do they want to engage in their health? Do they want to engage with your organization or your health? What are we asking them to engage in? And I think that answer comes with a little bit of trial and error, as well as I've said, listening. I think Mario has described some nice examples where they've gone into the communities, had people at the table to design and develop the interventions that create value. And so for people who do not initially want to download all of your apps that don't talk to each other, that haven't been updated in 3 years, the path to engagement is probably
You
through the
see me
primary
with my
care.
phone trying to deal with Blue Button and the Epic My
That's right.
Chart.
I mean, so the path is to leverage the relationships that matter to them. And so whether it's the pastor or the pharmacist or the nurse practitioner or the community healthcare organization or a patient advocate, it's about being flexible and intentional about leveraging those relationships to engage patients as a first step. I think we also have to be careful that a lot of the studies around patient engagement and patient-reported outcomes of all of these cool technologies is still a bit lacking in validated measurement, not just for health outcomes, but for measures of engagement as well as experience. And I think that story is yet to be told. But I think you've heard some nice examples of it doesn't matter if they want to be engaged in technology or not. The idea is that we want it to be warm. We want people to feel cared for no matter what tool or community or relationship they're in. And we want to engage them the way they want to be engaged. And if even we could move them one step to the right, that's a first step.
I would also comment that tech challenge is a misnomer because you have populations that can play Candy Crush. If you can play Candy Crush, you should be able to engage with a mobile app that is simplified. What we did at our company was we created a one-tap environment. We teach people who are 40 to 98 years old, one tap is all you do. And you do it every day, and you do it every day, and you do it every day. And we're going to jump in when you miss it to remind you. That level of simplicity, when you do it, as Adrian mentioned, you have to build it into the community. You have to go to the patient and say, all right, can you do this? No, I can't do this. Can you tap here? Yes, you can tap there. Oh, great. You already did it. It changes the behavior and the profile of the expectation. There's incredible apps out there that you look at really sophisticated, but it's challenging if you're not building it the right way, in my opinion.
Well, and that leads to one of the questions here, that what initiatives, this person asks, what initiatives do your companies have to encourage more Latinx representation in health tech, either directly hiring or partnering with Latinx entrepreneurs? You know, fair disclosure, I did a story on Mario, and one of the things that I talked about was the fact that if you look at venture capital, which is what helps seed young companies, particularly in health tech, you know, you've got like 7 people who are Latino out of 200 in a company, you know, or of color even. So those relationships mean that a lot of times people just don't get access.
I can talk about our experience quickly so the rest of the panel can talk about their experiences. But the reality for us, Bertha, has been we're going to create our ecosystem, and we follow a philosophy. If we build it, they will come, right? So we're creating solutions for the community, and then we're empowering the community to be the health advocates. Our model is a peer mentor model.
But this question speaks more to, you come from a business background, so you were able to do it. What about young tech entrepreneurs who want to get in there?
I'm getting there. I'm getting there. So what we start is with the community, and we identify the patients, we bring them on board, we make them coaches. So there's a generational aspect to it. The second thing that we do is the model that was described. We follow the promotora model because there's somebody in the community who is going to be that liaison. We tap into that liaison and we identify potential development pathways for that individual, he or she, coming into an organization and growing through the ranks. We're now talking to medical schools across the U.S. to figure out how we can get those healthcare professionals that look like us actually through the system and train on systems like ours in order to increase access. So there are ways. It's a challenge, but if it were easy, anybody would have done it, right? And we're trying to put a stake in the ground and say, hey, this is something that has to be done now. It's pandemic showed this is a non-debatable point. We have to increase access, and at least we think we have a model, and we love to partner with organizations that feel like that.
So, you know, there are a lot of organizations like yours that came out a year ago and said, we pledge to do more about equity. what are you doing to bring more Latinx people into STEM and to help them move up in the ranks?
Yeah, well, we see it's a critical challenge to address, and we really want to lean in to do our part. So we're doing things right now as far as education, as far as community engagement, raising awareness of the opportunities. But we're also, we really want to make sure that our company is a fabulous place for Latinx community to come to be employed. So we have employee engagement groups that really make sure that Illumina is a fabulous place for Latinx employees. We also feel like we have to help the next generation. So we have engaged with the San Diego community, provided the foundation with significant funding for their STEM education, focused specifically on Latinx. So we're trying to find different ways in which to support the current understanding across communities, diverse communities and vulnerable populations, making sure individuals from those communities feel welcome within our company and feel more understanding of our technology, but then also investing in the future and those educational programs that are so important. So we are doing that and very motivated to continue to do so.
And there's a question here, sort of two parts. It says, how do we ensure privacy in the avalanche of these digital solutions? And also, won't digital medicine lead to greater exposure to potential additional risks? Obviously, we've seen hospitals held ransom and their systems locked by ransomware. As we become more digital, are we exposing people to greater risk?
If I can jump in, I think that the risk for certain populations is not having access to the system. So what we're doing is we're putting our best foot effort, and we're putting constraints, HIPAA compliance, high-tech compliance, all the rules in place. And we're doing the best to maintain a confined environment. But the reality is, if you're going to wait and you're going to say, hey, because it might get lost or it might get stolen, you're not going to do it. You're going to start from a point where you're not ever going to be able to solve the underlying problem, which is we need to increase access. There are safeguards and there are methods of doing it, but you have to take a positive approach to say, hey, let's expand with the constraints in place and make sure that everything works in the right way. But waiting for it to be perfect, Bertha, in my opinion, is going to have us waiting for the next 200, 300 years.
And Bruce, last question quickly. AI can reduce health disparities or widen them. Can you talk more about how we might mitigate the ability, because if you can't afford, you don't have insurance to get that monitor, you're going to have to keep pricking your finger, right? Because you can't afford that.
Yes. Well, one of the things we've committed to is working with both the federal government and state Medicaids to be able to provide coverage policy that's reasonable and rational so that the reimbursement formula is not creating a disparity barrier within various communities. We've also partnered with the National Minority Quality Forum, and I can tell you down to the zip code level, the impact of diabetes on Hispanic communities down to the zip code. I can tell you where the disparities are. I can give you measurable impact as to what the disparities are. What we're doing is we're doing the next layer of trying to dissect that data to say, give me why. Is it access to a specialist? Is it what's the difference in their number of just basic office visits? What's the hospitalization rate, the use of the emergency room, to try to figure out. We hear this concept of food deserts. There are medical deserts. And if we don't have people with access to basic preventative care, how do we address that first? The patients would then say, okay, you can qualify for this with the insurance that you have. And we experienced it firsthand. We did a South Texas program in McAllen, Texas, where we worked with the community, that the community owned it. And once they owned it, their outcome scores and their clinical improvements have gone through the roof. but it's providing them the tool, the information, and the data where their challenge and where their issues are specifically to put clinics.
Yeah. No. So we are drawing to a close here, and it feels like we've just hit the tip of the iceberg on this topic. But I want to give each of you a chance to close on a positive note. What is encouraging you right now about where we are in the cycle of empowering technology for the Latino community? Adrian, let's start with you.
It's a softball at the end. I would just, so some closing thoughts quickly. If you come at some of the issues we've talked about through ethical lens, the four components we often talk about in the ethical world are beneficence, we want to enhance lives, do good, non-maleficence, we don't want to hurt people, autonomy, we want to respect individual choices, and justice, right? We want to maximize benefits in terms of fairness, equity, and impartiality. And I think everything we talked about today touches on those things. I see the data question and the interoperability questions, all those questions in part about patient safety and the desire to do no harm, right? That non-maleficence component that we're all committed to in healthcare. And inclusiveness. You know, we didn't talk about implicit bias that can creep into so many of these conversations, whether it's AI or the digital world that we're going to create, or how data is shared and what patients understand about how their data is shared. But it's a big, big beast. What encourages me about all of that is, I think if we look at it through the lens of empathy, the idea that we want to understand the cognitive experience of another, the emotional experience of another. We are morally wired to take care of each other, and we want to do something about what we're learning and imagining. Then there's tremendous hope for us to listen with intent and change how we engage patients across all populations more effectively to create a humane experience of health. That's what I'm excited about.
Terrific. Phil?
I think building on what Adrian just said is what gives me optimism is how patient-centric technology is allowing us to be, bringing these technologies to them in ways that can help them live healthier lives. And we have a lot of learning to do in underrepresented populations with respect to how to fully leverage, whether it's genomic information or technologies for the benefit of them. But what we've learned through the pandemic is that when motivated, we can move very quickly as a medical system. And I think this patient centricity will allow Latinx communities and individuals in Latinx communities to really engage, participate, and benefit from the evolving technology that's improving healthcare.
We seem to have lost Bruce for the moment. So Mario, I turn it to you.
Thank you. I'm hyper bullish on the patient actually having had a great experience during the process. The pandemic forced that experience. But once you've gone through that journey and you've seen that on the other side, your experience was just as good as it was before, or maybe better because lack of travel, cheaper, more accessible, the patient ultimately is going to start changing the dynamics. And we've seen it in our interactions with both the healthcare professionals and on the patients. We're in the middle there helping both sides. You see a systemic change. Patients are now embracing and understanding, yes, this is why I need to do this, because if I can gather the information and I can transmit it securely to my doc, and I have a process for me to do that I feel is going to bring value back to us, I'm willing to do it. And on the flip side, when you look at what we're able to do and how we're able to transmit that information directly to the physician, it really changes the dynamic of the patient relationship, and you start to see better health outcomes. When you start to see that, you start to see constraints and costs. So everything that was theoretical, you're starting to see nuggets of that occur. And we think that once the genie's open and the bottle's open, right, it's not putting it back. Now it's how do you build it the right way, empower those that need to be empowered to be able to manage their information adequately, put safeguards around how to do it in best practices. But we need to go forward, not take a pause, relook at the whole system. We've been doing that. And for the Latino community, especially I've been 30 years at this. Day one, access, issues of cost, issues of Latino misrepresentation in the healthcare system. 30 years later, we're at the same point. So we've learned the Latino community to do it for ourselves. So I think this is something that is going to move forward, driven by the community. And hopefully others can help us across the journey. If you're an advocate to the Latino community, raise your hand and help us solve these challenges, because they're the same. It doesn't happen Latino, Asian, African American. The problem is the same. It's just different shades of the same problem. And if you can solve it for one group, then it could be applicable to other populations all over the world. So I'm incredibly proud of what we've seen, and I think the future is here, and we just have to be advocates of it.
Great note to end on. Thank you so much, Mario Anglada, Bruce Taylor, Dr. Fabro, and Dr. Boise. And thank all of you for attending CHCI's Health Summit. Please keep tweeting about the summit and sharing your thoughts using the hashtag CHCI Summit. We hope that you've enjoyed our closing plenary for today, and don't miss tomorrow's big session, the Tech Summit, starting at 11 a.m. Eastern, with the opening plenary titled Our Digital Planet, Technology for Environmental Justice. Hope you have a great night.